All right. Hello and welcome. My name is Kim Concepcion. I'm the Wellness Coordinator here at Department of Health. And I'm really excited to welcome Allison Immel back for our third session. This session is on hormone replacement therapy. And before I introduce Allison, so we had I'm going to go over just a couple of housekeeping items. We had two previous sessions. Those are recorded and available both internally to DOH and externally. Those will be sent along with this recording to everyone who's been registered. This session is being recorded, and we're excited to have you. We are going to hold questions until the end so that Allison can get through her material. There should be plenty of time for questions. We have a transcription link in the chat or the captioner link in the chat. And we have ASL on the screen. Thank you to Amanda for our ASL interpretation. All right, so I'm sorry for those that aren't able to hear me. You might try logging out and coming back in. So Allison Immel is a board-certified physician's associate specializing in urogynecology and metabolic medicine for women, functional nutritional therapy practitioner. She's fellowship trained functional medicine clinician and your heart-centered vitality guide. Allison helps to educate women about tending to their temple through optimizing metabolic health, balancing hormones, gut healing, heart-led coaching. And she's worked with thousands of women over the last 20 years in healthcare and observed patterns, listened to hearts, and through her breadth of experience has gained lots of wisdom on what you need to feel amazing in your body. And so from here, I'll turn it over to Allison.
Okay, thanks for having me, Kim. The first two sessions, they were great, super fun. Your questions were amazing. We focused a lot on perimenopause and menopause and what the symptoms are and really what it is and why it's happening. And then we talked about nutrition and gut support and metabolic support, detoxification support in that perimenopausal, menopausal period. Now we're going to just get really focused on HRT, which seems to be a topic that everybody's really interested in. People have lots of questions about, and I want to just go through some information and tell you, share with you my clinical experience and then what I prescribe. And then I really do want to open up to questions because there are so many questions, personal questions when it comes to hormone replacement therapy. And I want to for sure make time for that. So I view hormone replacement therapy as something that is somewhat necessary in our time. We talked a lot about the adrenal relay last time and how one of the reasons that we are suffering in perimenopause and in menopause so much more is the lack of community, the exhaustion, the chronic stress, the overwhelm, just the having to carry it all, providing the emotional labor in a home, and then also going out and working a full-time career. And our systems, biochemically, hormonally, metabolically, weren't really designed for all of that. And so when we start to feel that hit in midlife, some people will try to just tough it through, but really, we have the opportunity to support and replace what's getting depleted earlier than it may have hundreds of years ago. And so people want to say, oh, I want to go through it naturally, and that's fine. You do whatever you want. I have no agenda. I just want you to feel well, and I want you to get the resources that you need if you want them. And so I do see people do better on hormone replacement therapy. And like I said, I'm just going to share my clinical experience and what I've learned over the years. I've been studying hormones for 20 years, especially in this demographic in the 40s, 50s, and 60s. And it's been phenomenal. I mean, the information, what I've learned from women has been consistent. And so now that we feel the confidence and the safety to prescribe hormone replacement therapy, I am just seeing people's health just, and so instead of people declining and that being the expectation, I get to see people's decline halt and then they start to improve and feel like themselves again. So I'm really excited that got asked to come back, and I'm excited to share this information with you. So these hormones are healing messengers. That's what hormones are. They are chemical messengers in the body. And so when they start to get really low, signals aren't getting transmitted throughout the body. And that's why we value hormones so much, because they are running the show. And so when they're not running the show, the signals get they just don't happen. And so we start to see quick aging, fast aging, more symptoms, and more immune problems. So let's dive right in. So the big ideas for today, that is, hormone replacement therapy has been around for decades. This is not something new. It's just something that was used in certain ways to fit sort of the times. And so we get to kind of bring it back with a lot of confidence. It is deemed safe, effective, and important for women's health now. History has been inconsistent regarding its safety, use, and administration and dosing. So we'll talk about that. Current practice promotes the use of body identical HRT, not synthetic, for symptom relief and chronic illness prevention, both. And then HRT is an effective first-line therapy for improving health outcomes and restoring one's sense of balance and satisfaction physically and emotionally. So we are calling it first-line therapy for women's health. So just a brief history of hormone replacement therapy. In the 40s, we were using pharmaceutical estrogen in the form of Premarin. This is conjugated equine estrogen. We'll talk about that. So it's made from mare urine. It is a synthetic. It's not identical to the hormone that's made in the body. It was primarily used just for menopausal symptoms, vasomotor symptoms, so hot flashes, and sleep disturbances. There was no progesterone that was routinely used, so there was a lot of unopposed estrogen being used. I'll talk about some themes for the time periods. There was relief without reverence. So they were just it was just a Band-Aid. It was really just a synthetic estrogen Band-Aid for vasomotor symptoms. In the 50s, we started seeing it promoted as the fountain of youth. And so this is, one of the ads that for Premarin was like a midlife woman celebrating and happy, and the ad says, let's keep her this way. So it was definitely not honoring like the feminine experience. It was more of like preserving youth for external satisfaction. So we also saw the continuation of the unopposed estrogen, and we saw endometrial cancer rates rise, and we'll talk about why that was. In the 70s, progesterone finally came in with the unopposed estrogen and the endometrial cancer rates rising. They were like, oh, what actually naturally prevents that endometrial lining from thickening? It's progesterone that's made by the body. So then they started adding synthetic progestins. We weren't using bioidentical or body identical progesterone at that time, and there was still no testosterone in women's care. In the 80s and 90s, it was really like a one size fits all. We saw a lot of combi patches. And then pellets started coming into play. These are still synthetic. So oral estrogen was really popular, and that was synthetic and body identical, but oral. And then we also were just using the progestin, the synthetic progesterone, not body identical progesterone. So it was still not perfect. And then it's when this is when we started seeing HRT used in disease prevention. So not just for like fountain of youth, menopause symptoms, we started connecting it with prevention of heart disease, osteoporosis, and dementia. In 2002, we had that big women's health initiative. The Women's Health Initiative has been around for forever. This particular arm of this study showed that there was an increased risk of breast cancer and cardiovascular disease in a certain demographic. But the problem with this, and I want everyone to understand this is where all the cancer fear came from. They were using synthetic estrogens, synthetic progestin in this arm of the study, synthetic estrogen, synthetic progestin, and they were reporting results on a demographic of women 65 and older who probably already had cardiovascular risk and some inflammation and some other comorbidities. So it wasn't studying body identical estrogen with progesterone, natural progesterone use in a perimenopausal and immediately menopausal group, which is, this group. This is what we're talking about. And so the Wall Street Journal found these data points, published a huge article, and then everyone got really scared. And so then clinicians stopped prescribing it. And I mean, really just this wave of fear spread throughout all of healthcare training. And this was the biggest crime. Peter Attia calls it the crime of the century. All these women were pulled off their hormones. So they'd been put on their hormones in the 80s and 90s. The progesterone had been added to protect the uterine lining, and then they got pulled off their hormones. And so this is where we saw osteoporosis boom, autoimmune disease boom, diabetes in women just boom. And so now you've got all these women on statin drugs, and high cholesterol boom, statin drugs, all these expensive osteoporosis medications, and the rates of cardiovascular disease, heart attacks, congestive heart failure, all increasing in women. And I see that clinically. I see the deleterious effects of the women I see, because I'm in urogynecology, so we do see everyone from their 20s to their hundreds. I see a lot of older women who were on HRT in the 80s and 90s, got put off, and then they are taken off, and then they said that their health just started to decline. So in the 2000s, there was more, this is when that nuance was lost. Like everyone kind of forgot about synthetic versus body identical. They were not comparing oral versus transdermal, which we'll talk about. They weren't comparing progestins versus progesterone, and they weren't talking about starting hormones in women's 40s and 50s. It was just like, it's all gone. Hormones are bad. We're not going to put anybody on hormones. And so then this is what I was talking about. We see this bone loss, this cognitive decline, metabolic dysfunction. When we talk about metabolic dysfunction, we're talking about cardiovascular disease, hyperlipidemia, like high cholesterol, diabetes, prediabetes, obesity, weight gain. And, the mood piece is huge. Mood and chronic stress, it was not being talked about in the 2000s. We talk about it now, that's for sure. So we started to see a resurgence of hormones. I was practicing functional nutrition in the early 2000s, and we were pushing for hormone replacement therapy, like body identical. And then when I went to PA school, which is conventional training, there was like, do not do hormones. But I knew clinicians, like when I went out on rotations, I knew clinicians who had been practicing through all of this who were definitely still prescribing hormones. And those patients were healthier and they were happier. So we start to see in the 2010s, the growth of the bioidentical hormone replacement therapy field, like getting compounded bioidentical hormone replacement therapy because it was safer than what was available before. But I can help clarify that too. Bioidentical, compounded, or bioidentical doesn't mean compounded. We have commercially available bioidentical, body identical hormone replacement therapy. And then testosterone was cautiously reintroduced for women for libido and vitality. So now we really focus on accurate dosing, transdermal estrogen, real progesterone, and individualized testosterone therapy. And we are also taking into account women's personal trauma, their stress physiology. So looking at cortisol levels, looking at catecholamine levels, looking at overwhelm, and supporting women in those realms, as well as providing hormone replacement therapy, looking at mitochondrial function, oxidative stress, the way that we detox and clear waste out of the body, and then sleep, and then, like I said, nervous system regulation. So all of these things play into how well your hormone replacement therapy is going to work. And we did talk about that. At the last lecture we're talking about gut and nervous system regulation. So now we are prescribing hormones with confidence and knowing that we are doing the right thing for women. So why exactly do we want these hormones? So we want to get our brains back, turn our brains online. Brain fog is one of the biggest things, and trouble concentrating, one of the two biggest complaints I hear in my patient population. To chill out and to get to sleep, we definitely see anxiety ramping up, irritability increasing, and then people not being able to get to sleep and people not being able to stay asleep. I tend to talk really fast. So how's my speed? If anybody could just give a thumbs up or a clap or, okay, thumbs up. All right.
As the interpreter, if you could slow down, that would help for clear interpretation. Thank you.
Okay, the interpreter asked that I slow down. Okay, thank you. It's complex stuff, so I appreciate you saying that. Okay, so to chill out, as I was saying, to get to sleep, to get turned on and to stay turned on. So for arousal, sex drive, a desire for even intimacy. So sometimes when those hormone levels start to drop, our nervous systems are more wired. So we actually go into more of a protective mode. And sometime maybe it would be nice to come back and just talk about sexual health and intimacy. Those are topics that people are feeling more and more comfortable to come and ask questions about that. So I love having those conversations. to build bone density and prevent fractures. So we know that estradiol helps to regulate how calcium gets put into the bone. So low estrogen increases your risk of osteoporosis. And we'll talk about that in a minute too. To prevent dementia and cognitive decline, estrogen receptors all over the brain, and testosterone and progesterone. To prevent heart attacks and diabetes, to keep our skin supple and strong, that prevents all kinds of skin tears, injury, and then to keep hair on our heads. Hair loss is it's a troubling thing for people to come in with. It's very disconcerting. To make healthy muscles and to make healthy cholesterol. So we use this slide at the first lecture. If you just want to peek at this, these are all the signs and symptoms of these particular hormone deficiencies. Hot flashes, super common. And that's one of the signs that we use, or one of the symptoms that we use to gauge if the estrogen therapy is actually working. Mood swings and irritability, not being able to sleep, definitely cognitive changes, joint pain. So chronic musculoskeletal pain, especially that starts ticking up in your 40s, could be due to low estradiol. Progesterone deficiency can be irregular or heavy periods, having really short periods. So if you've had regular 28-day periods your whole life and now you're having 26, 24, 21-day cycles, you're bleeding every 21 days, that could be a deficiency in progesterone. Just getting really irritable with everybody. Oftentimes I will hear from women like, oh yeah, my family says that I'm just awful to be around. And then water retention and bloating. Testosterone deficiency, obvious ones, low libido, low sex drive, inability to orgasm, reduced muscle mass. But the two big ones that people don't think about with testosterone are depression and focus. And so I have seen a huge uptick. I've never seen just in the last 2 years of so many perimenopausal women getting put on ADD medication. And I mean, I completely understand the need because your brain starts, especially this point in our lives, like in your 40s and 50s, you've like kind of figured your stuff out. You want to be productive at work. You love what you do. You actually have this wisdom and you want to be of service. But your brain is not moving as fast as your wisdom. It's not as fast as your wisdom is full. And so you want to share all this, but you kind of can't keep up like you used to. And so then women will go to their provider and then they will get on ADD medication and it can help focus your brain, but it causes your nervous system it kind of wrecks your nervous system. And I'm not bagging ADD medication, though it sounds like I am. I just want people to know that attention and focus can be signs of blood sugar dysregulation or issues with attention and focus, blood sugar dysregulation. So skipping meals and eating too much sugar, too many energy drinks, that kind of thing. Sleep problems, low estrogen, low progesterone, and for sure you got to look at low testosterone. It could also be some mineral deficiencies, which are super important to look at, but the ADD medications and the ADHD medications focus on really one component of the whole perimenopause picture, and they can throw other things out of balance. Same thing with getting on an SSRI and perimenopause and menopause. You come in and you're just like, I feel awful. I feel depressed. I don't want to go to work. I just don't feel like myself anymore. And because of that, hormones falling out of favor for first-line therapy for women for these concerns, or maybe even not even being acknowledged as first-line therapy for these concerns, people are prescribed SSRIs, and they can be so helpful to pull you kind of out of the trenches. And I'm not knocking it. It's just so important to pan out and look at the whole picture. Because what you don't want to do is target two of your, loudest symptoms and then miss out on therapy for the other things that could be, that could pop up later. So it's really important to mention that. Okay, so estrogen. So we're gonna cover 3 main hormones for HRT today. We're not going to include like growth hormone and DHEA for the sake of time. So estrogen is the one that everyone gets, excited about. I don't know. I get excited about all 3 of them. So, but estrogen people worry the most about. So estrogen protects the heart, protects the bones, and protects the brain. That's what we say. So heart disease is the #1 cause of death in women, whether it's from coronary artery disease, congestive heart failure, or arrhythmias. And so estrogen softens the blood vessels. It makes them flexible. And so one of the biggest risk factors for cardiovascular disease in women is high blood pressure. And so when your blood vessels are stiff and inflexible, they can stay, they stay tight. And so then that actually increases your blood pressure. Estrogen softens them. Estrogen softens everything. It makes everything supple and juicy and feminine, and that's important. You know, we with complex chronic stress, we start to lose that femininity, that feeling like yourself. We kind of just go into survival mode, and like it's a stiffness and a protectiveness, but really like that, this stiffness. So estrogen comes in and it softens things, including your blood vessels. There's a great, oh, I have this on the wrong line. I'm sorry. I'll change that here in a minute. Okay, so estrogen protects the heart. It also lowers cholesterol because it regulates cholesterol synthesis and fatty acid metabolism. So one of the first signs we see in perimenopause and like maybe the need for estrogen is your LDLP goes up. And that's an advanced lipid panel marker. So you might notice that all of a sudden, like you didn't have high cholesterol, and all of a sudden you go and get your labs done and you have high cholesterol. Like, wait a second, I didn't change anything about my diet. I didn't change anything about my exercise. But now they're talking to me about maybe getting on a statin. That's the loss of estrogen. We also see an uptick in prediabetes. And so estrogen regulates glucose metabolism and how efficiently you put sugar into the cell. And so that's going to affect your insulin resistance too. And so you will see an increase in insulin resistance and prediabetes all of a sudden. Diet didn't change, workouts didn't change, like lifestyle didn't change, just that your estrogen started to drop. Estrogen also protects the bones. So osteoporotic fracture significantly increases morbidity in women. And this is a big deal. Like once you fall and break a bone, your quality of life can significantly decrease because mobility goes down, you're more sedentary, and you just are at risk for more fractures if you don't get on it. You can take an osteoporosis medication, which are selective estrogen receptor modulators. So they actually, they use hormones to put calcium in the bone, but you don't necessarily, they were created because everyone was afraid of using estrogen. So they were very specific to improving bone health without having the other effects on the body, any proliferative effects. People were worried about breast cancer, right? So instead of being on and I'm not saying get off your osteoporosis medication, but instead of getting on an osteoporosis specific medication, you can take hormone replacement therapy, which will cover your osteoporosis and your heart and your brain and your mood and your sex drive and your vaginal health and all those things. And I did include some studies if you wanted to reference those. And then estrogen protects the brain. So estradiol deficiency directly contributes to the loss of neuronal function and antioxidant protection. So you are at greater risk for cognitive decline as your estrogen levels drop. It's not just like a fact of aging. And so this is where we do start to see some of these, like, they feel like glitches. People are like, what was I thinking? Or what was that? Or, oh my God, I used to remember everything and I can't remember anything anymore. I hear that a lot instead of like, you don't forgetting people's names or forgetting how to get somewhere. That's later stage cognitive decline. But like the early things where you're like, oh my God, I cannot remember that thing. And that happens to everybody, and that could be thyroid too, but it's really, really common in estradiol deficiency. I can't wait for your questions. Okay, what else? So estrogen also treats hot flashes and temperature dysregulation, those vasomotor symptoms. There are medications out there available if you can't tolerate estrogen for some reason. And sort of the estrogen metabolism stuff is just like too much to work on, like changing your diet completely and getting on liver support. There are medications that can help with just hot flashes. Sometimes tricyclic antidepressants or other SSRIs can also help with hot flashes. Estrogen improves the quality and the glow of the skin and prevents hair loss. We have a lot of our patients putting their vaginal estrogen directly on their faces. There are compound estriol and vitamin C formulations that people can get from compound pharmacies to put estrogen on your face. So take estrogen in the body, you can put it on topically, and it will improve the turgor and the suppleness of the skin. It improves blood flow, collagen, hyaluronic acid in the skin naturally. Estrogen keeps you hydrated everywhere, so it will address crepey skin, and it also really protects vaginal health. In urogynecology, I prescribe vaginal estrogen like it's going out of style. When you take hormone replacement therapy, it doesn't always, typically doesn't bind to the front part of the vagina where the urethra and the vestibule are. In urogynecology, pelvic health medicine, we see a lot of urinary leakage and incontinence. And so we put a lot of estrogen on the front of the vulva. So again, if you're on systemic therapy and you have urinary symptoms or vaginal dryness or painful sex, you'll want to use a vaginal preparation as well. But that's in a later slide. Regulates glucose metabolism and fatty acid metabolism. We just talked about that. Totally evens out the mood, and that has a lot to do with insulin sensitivity and serotonin. It helps you sleep, it gets rid of belly fat, and it helps you build muscle. So treatment forms are oral pills. It's definitely less favorable in clinical practice. The increased risk of stroke and heart attack was associated with oral estrogen. Or oral estrogen has to go through the liver. Anything that has to go through phase 1 liver detoxification can increase your risk of clots because it might get stuck there. It just is a slower, if you have slower estrogen metabolism in the liver, then you might be one of those people who has increased risk for developing a blood clot. But a lot of people do well in oral. I see so many people right now that I want the safest and most certain hormone replacement therapy. So you can use oral if you're working with someone who's really familiar with oral and feels comfortable with it, but my preference is transdermal patches. They are the most common now due to the safety, and they, like I said, they decrease the risk of blood clots, or they have a decreased risk of blood clots. There are transdermal gels and sprays like Divigel that's commercially available. These things just get kind of expensive. So this is great for people who can't handle an adhesive off the patch. Compounded cream, so you can totally get a body identical compounded cream that's customized just for you, and that works well for a lot of people who can't tolerate the more commercially available preparations. And then vaginal rings and suppositories. So this is the FemRing. This has estradiol in it. You insert it into the vagina and it stays there for 3 months, and it just gives you a continuous release of estradiol. This is a great option for people who don't want to put a patch on and change it every 3 to 4 days or once a week. This is my most prescribed estradiol preparation, is the Vivelle dot patch. It's the one that seems to do the best for most people. Like I get target values on their labs, and it bothers their skin the least. It just works well. People are happy with it. But there are generic ones too.
Allison, can you slow down just a little bit?
Yeah.
Thank you.
Sorry. Is there anything I needed to repeat?
No, there was just a request in the chat.
Yeah, thank you. Yeah, if there is something that you want me to go back over at this point, we're at the halfway point, since I've been going so fast. If anybody wants to just say like, hey, can you say that again? I'm happy to go back. Yeah, you can pop it in there, and Kim, feel free to interrupt me. So side effects of estradiol treatment can be breast tenderness, bloating, swelling, a shift in your mood, increased irritability. And so I'm looking for those subtle initial changes in your symptoms that may be bothersome. A lot of women, most women, get on an estrogen patch and they are just happy. Like right away, they're like, oh my gosh, that treated my hot flashes. I can sleep through the night. And it just takes them back to their baseline. But some people will experience these issues, and this is usually associated with estrogen metabolism, how you're able to clear estrogen out of the body. Progesterone, so we call it nature's Valium. It upregulates your GABA receptors, so it makes those GABA receptors more available. And GABA is a neuroinhibitory neurotransmitter. It calms you, it quiets the mind. So we use a lot of progesterone for sleep disturbance associated with perimenopause and menopause. You definitely take it at night. So that's gotten lost in translation. I mean, anytime I see a patient, I'm writing, like I definitely type out the directions for everyone, and then the directions on the medication say to take at night. Every now and then it gets missed, and someone will take it during the day, and they're like, oh my God, that progesterone. I'm so tired. I'm like, oh, when'd you take it? Like, I take it every morning. So I can't even imagine going to work and trying to think with progesterone. I take it and I'm like ready for bed in half an hour. So it really does quiet your mind. It really helps you to shut off the day, and just it balances cortisol, which is why we see it dropping in your 30s, because cortisol goes up, progesterone goes down. And so that's why it can keep your mind so active. This is usually the first place we start with any HRT. If someone's like, I just want to go slow, and what's something that I can start with? Because the levels in perimenopause bounce all around, we don't do a lot of testing. for estrogen and progesterone, but progesterone is always low. Always, always, always. And so it's a safe thing to start with for most women. So helping people sleep better and calming their nervous systems. I mean, that if I only did that, I would be happy that of the things that we're providing for women. Again, it lengthens your fuse. It makes you less irritable. It just makes you feel more calm because of those GABA receptors, and it extends your periods. So we talked about periods shortening from 26 to 25 to 21 days. So when progesterone is it's responsible for the length of your luteal phase, which is the second phase of your cycle, and it's produced by the corpus luteum. So your body, sorry about that, not at work today. Your body, your ovary will release that egg. Egg goes out, and then that little follicle will involute, and it creates this yellow, rich progesterone-rich corpus luteum, and that is what keeps the lining of the uterus in place in case of implantation. And so then when that progesterone declines at the end of those 14 days, the second half of your cycle, that's when you shed. But a lot of women will shed at 21 days because they just don't have enough progesterone, so that progesterone just declines early. And so a shorter period is one of the first signs of low progesterone. It does balance estradiol to prevent endometrial growth. And so we say that if estrogen is the fertilizer for the lawn, then progesterone is the lawnmower. So estrogen will build that uterine lining, again, preparing for implantation, and then the progesterone keeps it there. And then again, when the progesterone drops, you'll start to see bleeding. So if women were put on, before when women were put on estrogen without progesterone, their linings were just getting really, really, really thick, and there was no checking of the progesterone to kind of keep it there, or to keep it short, because they oppose each other. So when we put people on HRT, sometimes they will start to see abnormal bleeding. It doesn't mean they have endometrial cancer. It just means that that lining is getting a little too thick for the amount of progesterone that's there. And we'll talk about what you need to do if that happens. If you have had hysterectomy and you've been on hormone replacement therapy, just estrogen only, you still can benefit from progesterone for all the other reasons we just talked about: sleep, mood, balancing cortisol, irritability. Intolerance can happen when you have lots of gut problems. I see this all the time. So if your metabolic pathways are congested, then you may not be able to tolerate progesterone very well, again, because it's an oral medication. You would probably benefit from transdermal. So using like a compounded progesterone cream. You can even use a commercially available one, just the doses tend to be too low. So if you can find it online by yourself, the dose is probably not high enough. They're usually like 25 or 50 milligrams per pump, and we use 100 to 200 typically in HRT. Some people have a paradoxical experience. They actually get more irritable and more anxious. So those folks would actually do great with a transdermal preparation. So the forms for progesterone, mainly capsules. We use Prometrium or generic Prometrium, or you can use a compounded oral progesterone capsule. The progesterone capsule has peanut oil in it, and some of them have a red dye in it. And I have people who are just super sensitive and they can't tolerate any of that stuff, or it's a preference. They're like, I don't want any of that stuff. So you can get a compounded oral progesterone where you can get 100, 200 milligrams. Some people who need a little less can use 50. So that's what's nice about compounding, but most women tolerate oral progesterone quite well. Vaginal, there are gels, creams, and then rings. I don't use any of those in my practice. And then transdermal, like we talked about with using the over-the-counter creams, then there are patches, but they're all synthetic, which we don't use because remember, the synthetic progestins were associated with those increased risk of breast cancer in the Women's Health Initiative. Intrauterine progesterone, people ask all the time. They're like, well, what if I just take my estrogen patch and then I keep my IUD in? And I say, that's okay if that's what you want. So if their primary concern is just preventing endometrial lining thickening or endometrial cancer, the progestin IUD is sufficient. But if you want the sleep benefit and the mood benefit and the cortisol balancing, then you're going to want to take the oral progesterone. You can still leave your progestin in for contraception because oral progesterone does not provide contraception. Just remember that. HRT does not provide contraception. I don't have that on a slide anywhere, so I'll say it again. HRT does not provide contraception. But this can be, I mean, if people want to keep their IUDs in, that's great. They can still benefit from an oral progesterone. They might need to do a lower dose, but they can still benefit. Some side effects will include headaches, bloating, breast tenderness, mood changes, stomach upset, and weight changes. This is all a metabolic issue. It's like never really the hormone's fault. It's usually chemicals in the environment, sluggish metabolism, need for liver detoxification, often diet, or gut health. Okay, testosterone. Testosterone definitely improves sex drive. We treat hypoactive sexual desire disorder. It's really important to know that all testosterone treatment for women is off-label. There is no FDA-approved product for women specifically, but we use a lot of testosterone anyway. It is becoming more and more recognized, and I know the FDA is working on a preparation for women, but for right now, we're using it off-label. But we're all trained in it. We're all comfortable with it. Testosterone, in addition to improving sex drive, it improves mood, improves muscle mass, reduces fat mass, improves insulin sensitivity. So again, addressing prediabetes, improves energy for sure, brain fog and poor motivation. I forgot to put on here attention and focus, like I was talking about with the ADD stuff, but it definitely helps just kind of zone you in. That's getting into like your masculine brain, right? The feminine part of us is circular, tracks everything. We are thinking about 100 things at once. The masculine part of us is very direct, very linear. We all have everything inside of us. And so sometimes they get out of harmony. And so when our testosterone drops, it does have masculine energy, masculine not meaning man, male meaning more just like direct and linear. And so we start to see some of those decision-making, some of our decision-making abilities decrease just a little bit. So the testosterone helps with that. We become more decisive just a little bit. We are able to access that part of ourselves a little more readily instead of forcing it. There's a lot of forcing. We do a lot of forcing, kind of overcompensating, trying to make our way through things. Like it's like we knew we could do it before. Now we lack the hormones to actually implement it with ease. And so then we force. So that's what I see a lot in women is just this resting. Like, I got this. I got this. Like I said, it has to be prescribed off-label. And we use low, precise dosing to prevent virilization. So hair growth along through here, clitoral enlargement, and voice changes. So, I mean, I start everyone really low and we go slowly, but I will see people who've been started on higher doses and definitely have seen clitoral enlargement, low voice, and a lot of virilization. And the hair growth can improve. The clitoromegaly doesn't really go down. And then the voice changes. The voice change, unfortunately, in most cases is irreversible. The forms that we use are gels and creams. We use the topical application of Androgel. It's only for men. I mean, the doses are only for men, so 25 or 50 milligrams. And so we will prescribe Androgel and we'll say use 1/10 of the packet or use 1/5 of the packet. So I typically like to start people on a compound so we can identify their dosing, because with a compound, I get to regulate exactly the concentration of the testosterone. So they'll do the compounded testosterone cream for like a month or two. We identify the dose, and that way we can switch over to an Androgel, which the reason we do that is it's much more cost effective. But I really, unless someone's had experience with testosterone replacement therapy before, they know how they're going to feel on it, and they're really good at guesstimate math, I always start with a compounded cream. And it's not crazy expensive. It's like $30 to $60 a month and can be really worth it for some women, for most women. But it's personal preference. We are still waiting, for an FDA-approved, insurance-covered medication. Injections are available, doing like once a week injections, and pellets are available. You can implant the testosterone under the skin. These are great low maintenance options, unless you don't like giving yourself injections. You just get big doses at once, and so it's a little harder to regulate. Maybe I'm a control freak, and I don't want my patients like going away for a month and then struggling and suffering and coming back and saying, oh, it was horrible, it was miserable, I just was so irritable for a whole month. I don't want that. I want you to be able to adjust it by day, or at least by every 3 or 4 days. And so the patches, the gels, the creams, they give us a lot of control. You get less control with the injections and the pellets. But once you figured out your dose, the pellets and the injections could be a great option for you just because it's less maintenance. Okay, so this is what I use. I use a transdermal estradiol patch ranging from 0.025 to 0.1 milligram per 24 hour. Again, the Vivel dot or a generic. If you have a known adhesive sensitivity, use a Vivel dot. I use oral Prometrium, 100 to 200 milligram cap at night. Topical transdermal testosterone cream, 0.2% to 1.0%. We do, the range is 2 milligrams to 10 milligrams. We start at 2 milligrams and work up slowly. You always want to
I'm
make sure
sorry,
you
this is the interpreter. Could you repeat that last part and just a little slower for me, please?
for the topical testosterone. Yeah. So topical transdermal testosterone cream. So we will do a 0.2% to a 1.0% cream, and that's 2 milligrams to 10 milligrams. We use libido and mood as a guideline for how well it's working. And then plus can't let you go without vaginal estrogen cream plug. So 0.01%, 1 gram applied intravaginally and on the urethra or the vestibule 3 nights per week. It's not actually hormone replacement therapy, but it is hormone replacement therapy for your vulva. It is part of what I do for most women. So this is what most women are getting in my practice. Very quickly, the difference between the conjugated equine estrogens and the body identical. Again, the synthetic stuff, the conjugated, is made from mare urine. It is not identical to the human body. It's close, but it still has to go through other transformations. And so that's why it's problematic. You're, again, using the liver. This is kind of indicative of, like, it just is telling of how much our livers need to be cleaned out too, that we're so sensitive. Body identical is made from yam or other plant sterols. So the big question is when to start. Now. Prevention of cardiovascular disease, osteoporosis, and Alzheimer's dementia is most effective if HRT is initiated in women's 40s, but you can start anytime, and you can take it for the rest of your life. There's just no solid evidence to suggest that a woman ever has to discontinue it. I have an 80-year-old patient. I just met her and I saw that her estrogen was crossed out on her med list, and I went in and I said, "Oh, so why did you stop your estrogen?" And she said, "Oh, my doctor told me I was too old to be on it." And I was like, and I hear that a lot, so I had no emotion around it. I was like, "Well, you can actually get back on it if you want. How have you been feeling?" She started crying. She's like, "I feel horrible. I don't feel like myself at all. All of a sudden, I feel so tired. I feel so moody. I'm not sleeping." I mean, this is in the course of a month. Her health just started to decline. So we got her on a patch. She was on oral. We put her on a patch so that I can sleep at night. But yeah, you can take estrogen well into your 80s and 90s. Metabolic considerations. Remember, the hormones are going to be using pathways. And if those pathways are cluttered up with all this other stuff, you'll have less efficiency of the hormone, and you'll have to use higher doses, which, you don't want to end up with vaginal bleeding. You don't want to have other problems with, you just don't want to have to deal with too much hormone. Avoid alcohol and sugar, anti-inflammatory diet. I kind of drilled that one home last time. Eat cruciferous vegetables. So the broccoli, cabbage, cauliflower, kale helps your body clear estrogen out and other hormones. You could take a daily liver support. Some recommendations are here. Sweating, moving, using sauna, just keeping your body moving and metabolically active. Zinc really helps those receptors. It helps make everything more efficient. So using zinc bisglycinate, that's most available to the body, and then clean up your gut. So if you've got gut problems, gas, bloating, constipation, diarrhea, the more you work on that, the better your hormones will work. So my most common questions with HRT, will estrogen increase my risk of breast cancer? So body identical estradiol therapy may actually decrease your risk of breast cancer. Body identical. It does not increase breast cancer, but it's not prescribed to women with active breast cancer. You can take it after you've had treatment, but most cases not prescribed to women who are actively treating for breast cancer. You can use vaginal estrogen for women who are being treated for breast cancer. It's just we don't typically. And then progestogen therapy is now understood to be the main driver of cancer formation. So just want to hit that one home with the Women's Health Initiative. Estradiol, body identical estradiol, and body identical progesterone have not been shown to increase your risk of breast cancer. Conjugated hormones, like synthetic progestin, have been shown to increase your risk of breast cancer. Will I start bleeding again on HRT after menopause? You can. Sometimes when there's just more estrogen than progesterone, or you can't clear it out all the way, the endometrium gets thickened and you can have bleeding. If you have bleeding, everyone's going to say you need an ultrasound. We need to measure your endometrial lining, and then you're going to probably have to have an endometrial biopsy with your gynecologist. And that's just a quick but not painless. I promise. I wish it were painless, but there will be some discomfort. I'm sorry about that. But it's just a biopsy to rule out any abnormal cell formation in the endometrium. And will I grow whiskers on testosterone therapy? Sometimes. We aim for those doses to be low. We're trying to get you to a physiologic place where you were before your adrenals started tanking in perimenopause. But usually hair growth is not a problem because we were starting so low and going slowly. So now I can open up to your questions. I'm sorry to talk fast. An hour is not a whole lot of time to give you everything I want to give you. So I appreciate your patience.
Lots of questions. Thank you,
Okay,
Allison.
let's go.
Just a minute. Can you take progesterone if you're not taking estrogen?
Oh, yeah, absolutely. That's a great question. So, like I mentioned, it's usually one of the hormones that we start first. So if you're not ready for estrogen, or if sometimes in perimenopause, the progesterone will drop and the estradiol levels are just fine, but your progesterone is definitely low. So starting on progesterone, even as early as your mid 30s, I mean, there are a lot of women with luteal phase defect who start progesterone in their 20s. And it's just remember, chronic stress and chronic cortisol elevations are going to throw your progesterone down. Cortisol goes up, progesterone goes down. Great question.
Can primary care providers prescribe compound creams, or do we have to get it from a specialist?
Great question. Anyone can prescribe compound. If you have a license, you can prescribe a compounded medication. It's just going to be, it'll come down to their comfort level with it.
Let's see. What's the difference between the use of estradiol cream you mentioned and suppositories?
Oh, that's a great question. So we're talking about vaginal. Vagifem estradiol suppositories are 10 micrograms per suppository. The estradiol cream that we use is 100 micrograms per gram. You don't need to math it out. Just know that when you use the cream, you're getting 10 times the dose of estradiol as opposed to the tablet. The other thing about the tablet versus the cream is that the cream covers the front of the vagina, the vulva, the vestibule where the urethra is. The tab doesn't. So I use my hands a lot, okay, for education. So if we're looking at the vagina, if we're going in like this, the tab's going to go deep into the vagina. But if you're looking at the front of the vulva, this is the vaginal opening, this is the perineum, and this is your anus. This is where your urethra is, right here. So you're missing the urethra in the front. So if you have painful sex, especially upon entry, and you have any urinary problems, using the Vagifem capsule, like the tablet, the vaginal tablet, isn't going to address those issues. It might help with vaginal dryness deeper inside the vagina, but it's actually not going to address the front dryness and urinary problems. Great question. I do have a preference when it comes to vaginal estrogen.
How do you know if you need HRT if you have an IUD?
Symptoms. So going back to that slide, which everyone will have access to, if you start to have brain fog, mood symptoms, your sleep's disrupted, hot flashes, those are all early signs of maybe needing some estrogen. If your LDL-P goes up, like if your cholesterol starts to go up or you start to see prediabetes, it might be worth talking to your provider about getting on estrogen replacement therapy. Oh, can't hear you.
I'm looking at the questions, trying to stay as general as possible right now. I think you mentioned this. Is there a length of time post-menopause where you no longer benefit from HRT?
No. So that was old. That was kind of old thinking, you definitely continue to benefit. And just kind of keep in your mind that anecdote about my 83-year-old patient. I mean, you benefit in your brain. Remember, the brain has all those estradiol receptors. And so the brain is going to benefit. I mean, we see so many women, 1 in 4 women with cognitive decline or Alzheimer's dementia, and well, so many with cognitive decline, but Alzheimer's dementia. And so we're protecting the brain by staying on estradiol therapy later in life.
Are side effects different or lessened with vaginal creams than patch or pills?
So you're talking about for systemic. Not with patches. So patches and a vaginal preparation are going to be similar. I'm going to close these. I'm like reading your questions as they pop up. I didn't put a balloon up there. I don't know what that was. If it's transdermal or topical, you'll have potentially fewer side effects. So people are talking about, the question I think is if you're using a vaginal preparation of HRT. It gets complicated, okay? So vaginal estrogen is a different animal altogether. That's lower dose, lower potency. When we're talking about HRT specifically, you can use a compounded cream that is a vaginal preparation and a transdermal patch. That's what I typically recommend. Lower side effect profile than like the oral. We don't use oral anymore. I just want to say, remember, when it comes to side effects, it's going to have to do with the input-output game. How well your body's able to eliminate hormone, metabolize it, and clear it, and not so much like your dose. If you have more estrogen than your body can clear, of course, you're going to have some side effects, that breast tenderness, maybe some bloating, mood swings. But if you, what I'll often tell women, you can either decrease the dose of estrogen, or here's a handout on estrogen metabolism, get busy. And that means like getting out alcohol, getting sugar, getting rid of sugar, regulating your nervous system, taking maybe some supplements to help your body clear things out of the liver faster. That's like a whole lecture on its own.
Does Medicare cover these meds?
Yes. Yeah. A lot of times. I mean, it really stinks. Like you put perimenopause, in for the diagnosis, and it often doesn't, but it very often will. But there is an out-of-pocket cost for a lot of this stuff if you're in perimenopause. Menopause, they cover it,
So that's the next question is, what's the typical out-of-pocket cost per month to do HRT?
Yeah, great question. So with the patches, it can be anywhere from, if it's out of pocket, it can be anywhere from like 30 to 60 bucks a month for the patches. Vaginal estradiol cream can be anywhere from 17 to like 42. But I tell people where to go for this kind of stuff. Progesterone is typically really affordable, $20 to $40 for a 3-month supply. Testosterone, like I said, with the compounded cream, it's like 30 to 60 a month. But once we switch you over to the androgel, you'll get a box that'll last you like half a year for like $60. So it's not cheap. This is not, but it's not crazy expensive. And I like to look at it from a global perspective. If you're looking at the money you're spending on other medication copays, so if you're on a statin, well, HRT can cover that. If you're spending a lot of money for a Prolia injection, HRT can cover that. So, there are so many good questions popping up through here. I could see them. I'm like, oh, I want to answer that. Oh, I want to answer that. But you can use coupons. So you can use your GoodRx coupons to get the cost down.
Would it be good to ask our general practitioner if they're qualified to address HRT questions / prescription?
Yeah, I think it's fair to ask about their experience with it. If someone tells you flat out no, then you need to find another practitioner. Like if they say, I don't know enough about that, then you ask them, well, who do you know? And you can go online, you can go on the Menopause Society and find certified practitioners. We have a lot in Olympia. We have a lot of certified menopause specialists in Olympia. I'm not certified. Everyone's going and getting trained in it, which is great. Maybe I should get a certification, I don't know, but I've just been doing it so long. So I'm like, you can't search for me and find me on there, but there are so many people in Olympia who are.
What are the options when you're on Stronzol for post-breast cancer treatment?
And Anastrozole. What was
Yes.
the first part of the question?
What are your options if you're if we're on that for post breast cancer treatment.
Yeah, you don't want to take an anastrozole. You don't want to take HRT while you're on an anastrozole. So you would focus on nervous system regulation. It depends on what symptoms you're treating. So if you're treating breast cancer, or if you're treating vasomotor symptoms like hot flashes, then you can try some of these other medications or more compound medications. Like there's Duovi, which helps to decrease hot flashes without giving you a lot of estrogen. A really good person to follow online, I'm trying to, Corrine Minnow. She is a board certified OBGYN who went through breast cancer, who is a huge advocate for HRT in breast cancer patients. So your options are minimal, they're minimized during active treatment, but a lot of women will go on HRT after they're finished with treatment. The anastrozole, like these estrogen blockers, will decrease the effectiveness of the hormone therapy.
So how does this affect trans men and women?
So the question's kind of general. I don't know if the question's asking about the
HRT recommendation.
Like how does it
Any
apply?
Mhm.
So the most important thing to focus on to prevent these kinds of drops is adrenal function. And so, I mean, this is a complicated question, but you can definitely, like I see a lot of trans men, and we treat the urogenital symptoms more than anything, because a lot of times trans men will be on higher doses of testosterone, so they're feeling really good. So a lot of the symptoms they won't actually experience, and then testosterone will actually convert over to estradiol, so they'll get some of those estradiol needs. They don't experience a lot of these vasomotor symptoms. But we do treat vaginal symptoms with vaginal estrogen.
Thank you.
And it works pretty well. Yeah.
Is the goal to bring hormone levels up to roughly what they are pre-menopause?
Yeah, we're not trying to take you back to your 20s. We're trying to just get you right back to that physiologic place right before. That's why we use low doses. That's why I like the patches. I start on a lower dose, and I'm tracking your labs, I'm tracking your symptoms. We're not trying to turn back time. We're just trying to support you and buoy you so that you can go and be strong and powerful in your femininity and also in your masculinity, but just to be full. Because this is what we hear all the time, is you're just depleted. You just don't feel like yourself again. So it's just trying to get you back to feeling like yourself again. So many nice things saying. I'm just going to say, you're so welcome, and it's so nice to be here. Thank you for having me. So many people they're popping up and saying nice things.
What do you think about a testosterone?
I'm sorry, this is the interpreter. I have to leave. Thank you.
Thank you, Amanda.
Last question. What do you think about testosterone supplement rather than a prescription?
So a supplement to boost testosterone is we didn't talk about supplements, but a supplement to boost testosterone levels is a wonderful idea. There are certain herbs and nutrients that can help to build your testosterone naturally, and actually decreasing like gut bugs and decreasing dysbiosis will actually help boost your testosterone too. Zinc is a big one. If you're going to do one little thing, take zinc. But yeah, certain supplement formulations are great. I mean, I use a ton of supplements.
Thank you, everyone. We are out of time. So many fantastic questions. I'm sorry that we didn't get to every question. We're going to have to stop our presentation now. Such an important topic. Thank you so much for being here. And thank you, Allison, for wonderful slides and all of your information. There was somebody in the chat that has her appointment in your office tomorrow.
I saw that.
Very excited. So thank you, Allison. And hopefully we're going to see you. Hopefully we're going to see you back. We're looking at potentially doing a talk on how to detox off of sugar. And so we're working on finalizing that. So thanks, everyone. Have a wonderful rest of your day and week. And I'll follow up with the recording as soon as I have it.
Thank you, Kim. Thank you, everyone.